Thank you. It's a very interesting topic regarding ST segment elevation, MI-ACS, and multivessel disease. So when we are doing an angiogram in patients with STEMI, 50% of the patients are diagnosed and having a multivessel disease. Recent guidelines indicate percutaneous revascularizations of regions not responsible for the acute event, that is non-culprit vessels, with a recommendation of class 2B. And numerous trials have documented the usefulness and safety of a complete revascularization strategy. If you look at the complete trial, 26% reduction in the composite risk of death from heart disease and acute myocardial infarction at an average follow-up of 3 years. Now, the decision making is very important when we are dealing with non-culprit vessels after doing the culprit lesion. Which non-culprit lesion is to treat with PCI rather than conservative treatment is controversial. How and when to perform a function evaluation of an intermediate coronary stenosis. Intermediate stenosis in non-culprit vessels represents 70% of the lesions in patients with STMI and multivessel coronary artery disease. And we all know that coronary angiography is not able to evaluate the criticality of these lesions and identifying plaque vulnerability features that could suggest an increased probability of ischemic recurrence. Now we have to resort to intracoronary imaging, and which intracoronary imaging facilitates to which non-culprit vessel to be done. If we look at the functional assessment, numerous evidence support the use of physiological evaluation of ischemia by means of functional flow reserve as FFR or IFR to guide revascularization in patients with stable ischemic heart disease. Randomized clinical trials have shown that use of FFR to guide decisions related to PCI of non-culprit lesions in acute MI is safe and effective, and that is shown in COMPARE Acute and DYNAMI 3. Differences between the two groups due to lower rate of urgent revascularization procedures. Multiple issues remained unresolved. First, FFR was measured during primary PCI in COMPARE Acute study and a median of 2 days after primary PCI in DYNAMI 3. It is not yet clear how and when to interrogate an intermediate non-culprit stenosis in patients with ACS. Factors contributing may be incomplete response to adenosine as a consequence of both an increase in macrovascular resistance and reduction in coronary flow. Non-culprit lesions can be associated with plaque rupture and distal embolization, which hinders vasodilator response. Increase in left ventricular and diastolic pressure, acute phase can contribute to alterations in myocardial perfusion. In short, IFR as an alternate to FR in patients with ACS, a study conducted by N. Tillenis et al. And who has evaluated IFR, FFR, and CFR concluded that IFR can overestimate the severity of non-culprit lesions in acute phase of ST segment elevation MI, while FFR can underestimate it. If we just consider the role of intracoronary imaging, numerous retrospective studies have documented that majority of plaques responsible for acute coronary events are mild at baseline and angiographic assessment. Coronary angiography alone is not a reliable tool for identifying stenosis. So pathological studies have shown to resort to IVUS OCT, and they have shown the thin cap fibroathyroma, high atherosclerotic load, greater than 70%, and small luminal area. So these IVUS and OCT represents plaque representation for non-culprit vessels. This is an OCT presentation. On the extreme right of OCT shows fibrolipid plaque with macrophage infiltration. On the middle is the large lipid load, and on the extreme right is the thin cap fibroathyroma, which shows the plaque unstabilization. Now, what about the role of non-invasive diagnostics? There are different non-diagnostic techniques like the echo, SPECT, CMR, or PET. Stress echocardiography is difficult to apply due to the basic kinetic anomalies and the risk of ischemia and or arrhythmic complications when performed in acute phase of MI. CFVR is also another technique with the Doppler transthoracic echocardiography in intermediate stenosis that could be done within 7 days of primary PCI, which is technically feasible and is associated with an excellent long-term clinical outcomes. CMR, late gadolinium enhancements, is good for the scarred tissue and is not superior to other techniques in identifying viable myocardium and predicting contractile recovery. PET is also another alternative non-invasive techniques for evaluating perfusion and residual myocardial ischemia, but its clinical practice is limited by the availability and high cost. Even a CT angiogram to non-culprit vessels suggests non-invasive hemodynamic evaluation using computational fluid dynamics, allowing identify plaques with high risk of instability. Even FFR-CT in detecting residual ischemia in patients with STEMIACS and Multivessel disease is modest when compared with invasive FFR. An algorithm was been produced by the European Heart Journal last year and has now been improved, and that was been published in last month, March 2023, in Journal of Clinical Medicine, which represents patients who comes in emergency coronary angiography, and angiogram is divided into two blocks, cardiogenic shock and non-cardiogenic shock. For cardiogenic shock, only culprit lesion revascularizations is recommended. For non-cardiogenic shock, that is the patients who are stable after doing a successful treatment of culprit lesions, 4 blocks are being divided. Lesions with low to moderate complexity and in which we consider that low amount of contrast could be used and high probability of functional relevance, that is the disease is greater than 70% stenosis, multivessel primary PCI should be offered. In patients who have got an intermediate stenosis, that is 40 to 70%, and after greater than 72 hours, the FFR or IFR will guide the PCI could be done or not. In patients who have got a complex lesions and in which upfront 2 or 3 stents is needed or the vessels are calcified, in such cases, stage PCI in hospital stay within 1 month is preferred. And if there is a CTO, non-invasive imaging is done. Another thing that has been added is the patient preference that was not present in the previous algorithm. Is patient preference should be included in the decision making, particularly for non-culprit lesions suitable for multiple options. In conclusion, decision to treat with PCI or to manage non-culprit plaques in patients with STMI with optimal medical therapy remains controversial. Assessment of functional critical lesions with IFR or FFR must be performed in subacute phase of ACS, preferably after 5 to 6 days, especially after large myocardial infarcts, otherwise it may be unreliable. The role of FFR, IFR in improving the prognosis of patients with ST segment elevation MI is limited, since cardiovascular events may derive from functionally insignificant stenosis but with characteristics of vulnerability. Thank you.